It is a top leading cause of death and also top leading cause of hospitalization, not only in the high income countries, but also in the low and middle income countries. It is a growing or emerging public health threat all over the world.
We've seen a lot of increase in cancer cases, and especially in Africa. Of course, there's also infections that are risk factors for cancer, like HIV/AIDS. And we do know that most of the patients, especially in Africa, will not really live beyond 2 years. Most of them, two-thirds, die within 2 years of diagnosis.
The impact of the disease in society means that there's a need to focus and to do more research so that we can hopefully prevent the disease instead of treating the disease.
I'm incredibly hopeful for the field of cancer research. When I began in oncology 20 plus years ago, the whole concept of a targeted treatment was really a bit of a pipe dream. I didn't realize how widespread that would be in clinical practice. The concept of cellular therapies was something that at the time was really just being investigated at most in mice, and I don't think there was a whole lot of optimism. All of these classes of therapies are now a reality.
The 21st century, the early 21st century, has seen an incredibly rapid advance in treatments for cancer. From those early tyrosine kinase inhibitors, monoclonal antibodies, we've seen the incredible advances in immunotherapy, antibody-drug conjugates, biosimilars, and of course, cellular therapies like CAR T-cells. So it's been an incredibly exciting time to be involved in research, and it was also an incredibly exciting time at the Lancet Oncology to be really at the forefront.
This is a more exciting time than ever, I would say, in the field of cancer research. I often tell my patients, and I think they find a lot of optimism in this, that the median survival for a patient with kidney cancer, the disease type that I focus on, is about fourfold higher now in 2024 than it was as compared to when I started in the field back in 2006, 18 years ago.
There are 24 journals at the Lancet Group, most of which publish oncology research. All the editors in the group are really interested in making sure that the research that we publish is going to have an impact on the people who are affected by the issues, whether it's a particular disease like oncology, whether it's a public health issue like screening, and whether it's an issue like end-of-life care, which is important in oncology and also in many other diseases.
Palliative care is sort of new in Africa, and one of the main things in palliative care, you can't say you have palliative care for oncology when you don't have pain medication, especially opioids. We know that cancer patients, 60 to 70% of them will have very severe pain. Our focus in the commission has been on advocating for access to pain medication for cancer patients and other patients, and access not just to any pain medication, but access to those drugs that are very strongly controlled in our countries. Educating and creating awareness at our policy level is very important.
Most of the topics that my group work, the stories come from the patients. Most of the time, the ideas or the problems or the research problems are from the community. So when it gets picked up and gets published, they view it as their success. My whole life and focus is all about life after cancer and how do we optimize and make patients, but not really on an individual level, but rather on a bigger patient population level. How do we get people to live better?
Oncology is a place where your patients become your friends, your family over time. And I often say that I see my sister, who I love very dearly, maybe 3 to 4 times a year at the most. And I have patients that I see once a week at times. So, it's really an excellent opportunity to build a bridge and get to know somebody incredibly well. And I do think that because you're facing such a difficult journey, a difficult point in their life, the relationship becomes all the more meaningful. One of the studies that we published in the Lancet that I think was quite transformative focused on a rare kidney cancer subtype called papillary kidney cancer. When we think about the landscape of treatments for kidney cancer, it's quite broad. We see that there's many therapies that are available for the general, more common clear cell type of the disease. There's very few treatments for papillary. Our paper in the Lancet focused on a rare disease clinical trial, one that was implemented throughout the United States and Canada, and established a new relative standard for this disease, a drug called cabozantinib.
What it meant to me to be published in the Lancet as just a dot on a graph, a number in a chart was actually incredibly meaningful. I remember whenever the results of PapMet was published in the Lancet and receiving a copy of the article, and I started crying when I read it because I could immediately identify myself in the data. It gave me a sense of purpose of what I'd been through. It made me feel like that what I'd gone through, which was a rather grueling experience being on treatment and going through literally a life changing experience as being diagnosed with stage 4 cancer, it really gave some purpose to that. I was diagnosed with metastatic papillary kidney cancer in 2016, 5 days after my 29th birthday. It was in the emergency room, completely unexpected, even though it had some symptoms that my doctors really couldn't explain for about 2 or 3 years prior to my diagnosis. Then, after my surgery, I had continued metastatic spread of my disease. And at that point, there was no standard of care for metastatic papillary kidney cancer patients. And I was recommended to join a clinical trial by my oncologist. It was a randomized trial for 4 different targeted therapy drugs, and I was assigned to one called cabozantinib, and I had a complete response within a year of starting the treatment. And I stayed on treatment for another 3 years after that. I've been cancer free ever since. And because of that experience, I have devoted my life to patient advocacy and giving back to the community that has given so much to me by saving my life. I'm the only one at the table that has been on these drugs, that has experienced the side effects. I'm usually the one that patients are having honest conversations about their experiences with their treatment. And that's why it's important for patients like me to have a seat at the table. I wouldn't be here if it weren't for Dr. Monty Powell. And I would not be here if it weren't for the work that was done and published in the Lancet. And because of the patient advocate that was on that study team that championed this trial. And so I consider it the greatest honor of my life to give back to this trial team, because I know that hopefully I'm doing the same for future patients.
From the perspective of the low and middle income countries, it's small steps, right? We see that people have become more aware, and as a result, we can see that cancers are downstage, meaning that people are presenting slightly earlier. And then, of course, we also see improvement in survival. So this is based on international work, local work, regional work. We always talk about moonshots, cancer moonshots, right? Journals are looking out for, like a novel work, but novelty is very relative. I think number one priority is looking at disparities and finding who is losing out in every sense along the cancer continuum. Geographical disparities, gender disparities. Mapping out disparities is very important, because when we develop interventions, it cannot be a generic intervention that you want to apply to everyone. For that reason, I feel very proud. I have one project where I've published in the Lancet Group as an original work. And I think that is what I'm so proud of. That is years of work. Then, of course, my involvement as a Lancet Commissioner in the Lancet Commission on Women, Power and Cancer. And then, of course, it was in the Lancet Global Health that we published a few years ago, where we looked at the economic impact on use of traditional and complementary medicine among people with cancer in Southeast Asia. It's called the Action Study. And the beauty is that we actually gave cost diaries to patients and collected data. So it's a lot of work. And I think I can be proud and say that no other project in cancer has done that big a job in a low and middle income setting. I think the commissions that Lancet has been coming up with is nice because of the diversity of the commissioners, which allows them, although they may not have the opportunity to publish their work in the Lancet as original research, the commissions actually give them room to bring in their insights, their experiences.
Working with the Lancet Commission is quite interesting because you get to meet so many people from all over the world. You learn through this process as well. You learn through this process. Lancet Commission's recommendations are really important in most countries, especially countries that are really trying to improve cancer control in their own country. For example, again, I'll give Kenya as an example. We now have a national cancer control program. We didn't have one, and those are some of the recommendations that the commissioners give. We now have a national cancer policy. The Lancet commissions really help us come up with policies, come up with the guidelines, come up with the strategies for oncology in our country, but also even make us understand how we need to put more into education and even having specialists or setting up cancer treatment centers. So there's a lot that we actually get from the commission. A few years ago in Kenya, we spoke about having 5 oncologists in the whole country. Then we had 10 for some time, and now we have over 60 young oncologists. The government at least has invested in training oncologists. Now, these oncologists are very young. They want to do research, but they don't have funding to do research. They have all these bright ideas, but they're not able to put them into action. So I really think we need to invest in research. We need to invest in implementation research. Quality of life is very important. Cancer will always be there. We might reduce the burden, but it will always be there. So we need to look at, if it's there, how do we support these patients to have a good quality of life, even survival? How do we prolong survival?
All of us in oncology and in the global oncology community are really looking forward to being able to solve some of the broad problems relating to inequities in access to cancer care, ensuring that the people that need treatment are getting access to it.
The values across the Lancet Group are shared by all editors and all journals, and we share a pool of reviewers, so the quality of the reviewers that we use is equivalent across all journals. We cover cancer research from bench to bedside, from basic and translational research to clinical research, but also at broader level, we also cover the public health oncology and the global health oncology. If we can't accommodate the manuscript in the journal where the manuscript was submitted to, we can always find another home within the family.
So if you submit a paper to the Lancet Weekly and it just falls out of scope or just can't be a priority for the weekly, there'll be an opportunity for editors from a number of other journals to see it at different stages. So for example, the Lancet Oncology, the Lancet Child and Adolescent Health, the Lancet Gastroenterology and Hepatology might see that paper and say, oh, that paper would be really great for us. We love it. It's novel, it's exciting, and it's really going to make a difference. And it's going to be really well accepted by the community that reads our journal. I think the topics that are really exciting for the future oncology are related a lot to technology. So of course we're really excited about AI and digital solutions to a lot of problems in oncology, everything from screening to diagnosis to treatment to designing a clinical trial. You can use AI and digital solutions. We're looking forward to seeing where cellular therapies go, CAR T cells. I've been here for almost 10 years, most of those at the Lancet Oncology. And over that time, I've built incredible relationships with some of our authors. You know, you start out working with them on a research article, and that might move to having an idea about a review or a personal view. You meet authors at conferences and have meetings, and you can see all of the activity and all of the work and all of the absolute brilliance that's going in to just trying to make the lives of their patients better, to improve treatments, to improve surveillance, to improve precision oncology, to improve end-of-life care.
The 4 main risk factors for cancer are man-made. It's tobacco, alcohol, sugar, and lack of physical exercise. With the 4 main risk factors for cancer being man-made, I really hope the future will move from treatment to prevention, because we can save a lot of lives by preventing cancer from happening.